I think we can start now. So I would like to welcome all of you for this roundtable on medication scheme in Europe. So we are 4 speakers with us today. So I will present them on the order that they will come in the webinar. So first we will have José Costa Teixeira from Belgium. He's IHE Pharmacy Chair and HL7 Belgium Co-Chair, and he's a product manager in healthcare IT. So we'll talk about Belgium. Then we will have Rutt Lindstrom from Estonia, who is data management analyst in Health Authority of Estonia. Then we will have Stéphane Spahni from Switzerland, who is IHE-Europe deputy co-chair and also IT architect at the University Hospital of Geneva. And then we will have Arianne van de Wetering from the Netherlands, who is health data exchange specialist at NICTIS. So we will start with the general medication context in Europe, so a small presentation, and then we will dive into the 4 different countries. So I will invite first José to present us this. Can we hear you, José?
Hi, sorry, I was finding the buttons. Hi, everyone. Thank you. Welcome. Yeah, let's start by setting the scene a bit to what IHE is doing on this topic and how IHE works. So very briefly, IHE has an established process, a mature process, to look at standards and implement and create implementable specifications based on those standards and based on the real world interoperability needs. So what we do is to take the use cases from the field, from some project, from some initiative like we have now in the medication schema in different countries, and we look at what are the standards that could be applicable here, and then we publish those technical specifications. Those technical specifications, they are created as integration profiles. They are part of a technical framework of IHE, which then gets implemented by software vendors, by hospitals, by government organizations, or they can be used also to specify tenders. I'll get there in a second. And this creates software that is conformant to those specifications. One of the things that IHE does as well is to validate if that implementation is conform to those specifications. So IHE has a range of tools, processes, and events like the connectathons, where we actually test if the implementations are conform to the expectations, to the interoperability. And basically we can see this as more plug and play. So the base standards like HL7, FHIR, ISO standards, DICOM, etc., they provide good interoperability mechanisms. IHE plugs into that and creates formats that are more appropriate to a use case or to that use case, and easy to implement, or more easy to implement, less variation, and more concise, let's say, standard implementations of specifications. So if you go to the next slide, please. In terms of pharmacy, where is our interoperability? So the IHE pharmacy domain is looking at several aspects of pharmacy interoperability. The key ones are the ones that are marked there with a star. So where we talk about prescription, dispensing, administration of medication, the supply of medication, and there's also medication records. We might be doing something soon also on monitoring, especially on the adverse drug event monitoring. And those are the key areas that we are focusing now. So supply chain is kind of separate because it's not only clinical. The rest is clinical, prescription, dispensing, administration, and the medication records. Those are the key areas of intervention now. So those are the areas of pharmacy where IHE has received requests and has started to produce specifications. We have prescription is we have this already in HL7 CDA, HL7 version 2, and so sorry, please the previous slide, please, otherwise. And FHIR, so we are doing now the prescription on FHIR. We have the same thing with the dispensing, so we have this in CDA and in HL7 V2. Now we are having this on FHIR. Administration, we already have some specifications on FHIR, and version 2 we don't have it in CDA. It was, oh, actually we do have it in CDA, sorry. And the medication records, this came to our group as an example of what I was just saying before. There was a project, and in this case was Switzerland, had an initiative to say we want to have the medication lists of a patient, and they were pioneers in that sense, and they joined the discussions in IHE to see what are the best standards. So that is something that all the credit goes to Stéphane here, to get IHE to produce some guidance and see how can we standardize the way that we exchange medication lists. That was the beginning of a step. Now we are doing the same thing on FHIR, and we are doing this also adopting the change of paradigm that we'll mention soon. So IHE does this, produces the specifications, and one important part is, as I mentioned, the fact that it's going to be, it can be referenced in tenders. Now the next slide, please. So IHE, because those are public specifications that are public domain, they are built by a committee of experts, and they follow a very mature process of figuring out what are the things that we can standardize and the things that we cannot standardize. Doing this, that gives IHE the possibility to create actually very mature specifications, and those can be used in procurement. So anyone can say, for our national prescription system, we want this to be compatible with IHE, and then we can say it's CDA, FHIR, or HL7V2. And as an example, we have two of these profiles, so our key two profiles that were defined at the time. This is 2015. They were listed in the profiles that are referenced by the European Commission. So that was something that's also important for us to see. This is not only a technical implementation, it goes all the way to procurement so that people can use it and can say, I want my system to be interoperable. The best way to say it's interoperable is make it IHE compatible. And if two entities are IHE compliant, then the guarantee of actual plug and play interoperability is much bigger. So the next slide, please. So pharmacy has been at this moment mostly driven by European participants. That's just I think a matter of coincidence. We are getting, on some of the topics, we are getting more and more people. We always get international participants from all over the world, and depends on the topic, I guess. Some of the topics at this moment have been driven mostly within Europe. We do address specifications that can be used for national and cross-border specifications. So what we do is not necessarily national or cross-border specific. One key example is product codes. We don't know the medication codes because we don't know the national, what's the national implementation going to do about this. We don't know what cross-border codes will be there yet. So we have both. We don't have a focus for either national or cross-border. We have to cover both. We cover standards, as I said. We cover HL7 version 2, CDA, and FHIR. And we have the profiles that I mentioned: prescription, dispense, administration, and medication lists. Those are the existing profiles. And then we have we also engage with projects like Unicom, XDHR for seeing what are the current initiatives for standardization in this area, and IHE is very interested in making sure that whatever IHE produces is supportive of those initiatives. Sorry. And finally, the topic for today is the medication scheme. So how does this appear, the medication scheme, in this constellation? What we want to do about this, and why is it important? So we have currently the medication lists as a profile, but during this discussion we realized that some countries, Switzerland, Belgium, Estonia, are moving to making the medication treatment not just a consequence of a prescription, but actually the trigger for treatment for prescriptions. For example, this is the vision that's been presented by several countries, and the medication scheme therefore takes a really important role, which is what is the patient on, or what is the patient supposed to be on, not as a report of something that has happened in the past, but actually as a driver for treatment. And this, of course, for the people that have more clinical awareness than me, this is extremely important for reconciling medication, for avoiding medication errors, for making sure that the patient's record is really the patient's record, regardless if the patient has treatments in one hospital and in another clinic, or if the patient has one treatment in one country and follows up on the other country. So having a patient-centered medication schema is extremely important, and the challenges is what we are going to discuss today. And for this, I would welcome Rutt to explain a bit how this is makes sense together, the medication overview. Thank you.
Thank you, Sule. You made my life really easy right now, because this is the visualization of what José just said. Like, this is actually the Estonian prototype of medication overview or medication schema. And this is pretty much the illustration of the approach that all three countries that José mentioned have. So even though this is like in Estonian and this is the Estonian prototype, this is how we generally see that this should work. So if you have the information about the treatments, but also you have the prescription still on the background as logistics items, you are, for example, capable of calculating how much stock the person still has at his hands at home. Are the prescriptions running low? Maybe you have to renew the prescriptions or do other calculations like that. But for the doctor, this is like a really clean, quick overview of what the patient is on right now. So if we can go to the next slide, please. This is an illustration how what difference there is between a prescription list versus medication overview. So when you have prescription list, and this is based on a true story here, this prescription list, this is something that I took from my patient portal, is that if you have something, the repeating prescriptions, you just like you get that every month or every 2 months or every 3 months or every 4 months, and nobody knows how long you've been on that product, for example. And the idea is that instead of this long list of prescriptions where things are like scattered like through time and at the same time they are like mashed together, you would have this clean view of medication overview where it would be like really clear, like this first item is 1 tablet continuously forever, or at least we see that the medication scheme, the first item is the starting date is actually like 2014. So it's like 10 years already. And the other one is something more current. And the other one is not based on true story, but I try to find examples from my own list, like what would be easy for the doctor to show, like to create this example here for that. So, and who is the prescriber is not always relevant, because the prescriber is maybe your GP, but the one who actually assigned the treatment or started the treatment a long time ago was another doctor, and we would like to see who started it and why. So to create these connections, the medication overview is a much better starting point. For some of the countries, the medication overview is assembled from the prescription list. Like you can take these prescriptions and get these clean lines out of that. But you can also use the medication overview as the starting point of new prescriptions or new treatments. And yes, that's good. What we are trying to achieve as well is that these treatment lines would actually create this line in history as well. So this is again another picture from the Estonian prototype, that if you have these treatment lines, you can take any moment in history and draw out these nice lines. Like the blue line shows that from this moment to that moment, this treatment was active for this patient. But the green line shows that the green line is the little one under the blue line, that this is when the patient was probably taking it. So the starting point of taking the medication might have been a little later. This is really because the patient did not buy it before, maybe like 1 week after the treatment started. And this is important for example, if you want to assess the adverse events, adverse reactions, or also the interactions between different treatments. like if the patient had not started actually taking the product, then probably that was not the cause of the adverse event. So for us, this gives many new options how to handle this information. And what we do in IHE, like we come together and we compare each other's implementations and how we see it. So every country has a slightly different approach to this. And then we come together and we compare like what is the approach that we all have? What are the common elements that we should standardize and what are most likely to work for all of us, even though we have slightly different approaches on a national level. So if you can go to the next slide, please. So in Estonia, we out of these countries here, we are the only ones who are implementing the fire specification and actually the same user interface for doctors as well. So we are having 2 layers of the same thing that we're doing here. And the fire specification, we would really like to have it conformant with IHE. But then the national implementation is very much driven from what we see from the business view as well. We are using Fire R5. The challenge is that we are using the prescription center, which has been operating since 2010, and we are not changing the prescription center. So we are creating another layer of medication overview, which is based on Fire, and this is really a new thing. But then at the same time, on the background, everything has to remain operating with the old legacy systems as well. And also we are operating within cross-border realm with our prescriptions, so everything that we do has to be conformant with cross-border workflows as well. And our main challenges are pretty much that it's a new thing for us. It's our first national full fire service, and all of the supporting services are developing in parallel, unless the ones that we decided that remain the legacy solutions like prescription center, but both of them create extra complications. The business rules have been very difficult. It's relatively easy to create a fire specification because that's only the part where you exchange the data. But the business rules, like how do you actually allow updating the treatment lines? What are the business rules? When do you create a new line? When do you just create a new medication? What are you allowed to change? These business rules are very complicated, and these are different for every country, I'm sure. And also having the similar data in multiple layers. You have prescriptions, you have dispensers, you have treatment lines. So they are repeating the same data in small changes, with small changes. And to have that all or in the UI design has been very difficult. Again, this is not a problem for fire specification that we are focusing on here today. So our future is that right now, as I speak, it's already live as the reconciliation of prescriptions in the web app, in the portal. During this year, we would like to get to the point that the medication schema becomes the main source of medication-based treatment. It would also show the history, and it would allow adding new treatments with prescriptions. And in the future, we would like this medication schema to feed into the EU patient summary medication section as well. And even after that, or in parallel with that, we would like to see how we can fit the hospital medication workflows into this as well. Thank you. That's all from me. Back to José.
Yeah, so from the Belgian side, some of the problems are similar. So I'll start with the awareness of how important this is. So the medication schema is one of the most important areas because of the clinical impact that it has for assessing the treatment and for driving the treatment of the patient. We already had in Belgium, we have already an implemented standard. So there is a national interoperability standard that's in place. And one of the key things in that standard was indeed the medication schema. in those specifications, the schema is authored by a GP, so by a healthcare professional that takes ownership and says, this is what I declare the patient to be known to be on. And this is now evolving into being a part of a modular summary. That's the name of the initial level of initiative for care sets. So we have several data objects, let's say in Belgium, we call them care sets. And the medication schema is part of that. So this is a set of modular elements that can be combined. For example, the medication plus the allergies plus the problems of a patient. And the medication schema has been one of the important ones. And the big shift was that the schema is no longer something that's, by looking at what the patient is on, we sign off and say this is what the patient is currently on. Is that we want to use, or the people that are analyzing this, they want to use the medication schema as the initiator of treatment. So because the assumption is I guess the same everywhere. Before starting any treatment, see what the patient is on, and sometimes it's an extension of a treatment. But always make sure that you start with that one source of the truth that the schema is supposed to be. I'll move on to main challenges. One of the things that we noticed was the multi-purpose nature of the schema. So if we ask what is the medication schema, that's already a tricky answer. It's the list of medications that the patient is or is supposed to be on. How do we define in details? Some of those can be tricky questions. That is one side. But the other side that we notice is the multiple purpose. Is this for the patient to be aware of what they have to take? Is it for the physicians to be driving the treatment? Is it for monitoring the quality of care? So actually all of those are true. There is interest from the patient. There is interest for the clinicians to see this. There is interest for all sorts of administrative and population health analytics. All these are valid purposes for the medication schema, which brings different requirements. For example, for a physician, we want to see more of a summary if what they want to see is what is the patient supposed to be on that could have caused this condition, or that could have, that if he had taken the medication, they would not have this condition. But for the patient, the output of the medication schema would be much more detailed. So that brings sometimes conflicting requirements that we have to handle. But that's a global challenge. It's not something that's only happening in Belgium. I guess it happens everywhere, because the moment that you have a list, the people that want to present this to the patient, they will say, we want this list to be very detailed, because that's what the patient is going to be taking. The people that want to see a summary, they will say, I just want to see a couple of lines by, not even by product type, but by classification, like is this person on blood thinners, etc. Those are that's one of the challenges. The other challenge was the authorship or responsibility of the entire schema. So if the dependency for the medication schema to be complete is that someone has to write it down and to validate it, and every time that there's a change, someone has to revalidate the whole thing, we have to find the right ways to make this very easy. Otherwise, it becomes an administrative burden to maintain good medical data, and that's something that is a challenge. Of course, also access control. What goes into the medication schema? Do drugs like drug dependency drugs or psychiatric drugs, are those visible for everyone, and is every detail about that drug, about the taking of that drug or the reason for that drug, is everything visible to everyone that wants to consult the patient's medication schema? Or maybe we segment this, some people can see something, some people can see everything, or maybe we say for the past lists, there is access control more strict. For the current lists, maybe the access control has to be a bit less strict, because maybe if you want to do history, then we don't need all the details. So all these questions, they come in all the discussions. So discussions are typically convoluted in a way that there's so many moving parts that it's hard to figure out where do we start. So that was one of the challenges. So what's the initial scope? And of course, the other one is medication codes. We have national codes, but we have several levels of national codes for medications. So we have a generic code. Let's say we have a generic group code. We have the package, and something like the reimbursed package or something like this, a detailed package. We have all these codes in the medication, and which one should we use? Well, if we want to have a summary, then we might want to use the higher level code, just the substance, to see if the patient is on this one. But if you want to give it to the patient, we actually want to have the detailed codes to see which is the drug, which is the color of the drug, that the patient is currently taking. And that is not only important for the creation of the list and deciding what goes into the list, but also for the evolution. So if I start a medication with one brand of a drug, and then if I continue that medication with another brand of the drug, is that the same treatment? We call it treatment line, medication treatment line. Is that the same medication treatment line, the fact that I start with one brand and I continue with another brand? Or are those two different lines? It might depend, or it will depend a lot on how the prescription was done and how the business rules that apply for this. So those were the challenges, that there's lots of business rules around this, and the evolution is not so simple, and there's not one solution that supports all the use cases in all their variations. Those were the challenges that we had to clear out functionally before. In terms of implementation, we have split this into the medication schema is one object that aggregates medication lines. And we started actually with the medication lines being the central thing. So as long as we can transmit the lines, then we can put aside or discuss aside what is the aggregation of the medication schema. Is it something that the doctor has to write, or is it something that some computer system can assemble and then someone just needs to validate? And how do we work with reconciliation? Those are different things. So we start with the medication lines to make sure that we can push things forward, at least to have the content out there. And then the medication schema is a discussion that we will still be having about how to aggregate this, how to put everything together, what are the criteria, etc. And then the other aspect is, as part of the modular summary and the whole care sets initiative in Belgium, the medication scheme and the medication lines, of course, they link to prescription, they link to dispense, etc. They link to several other care sets. So we are making something that's not isolated as a medication schema. We are making something that has to be getting information from or contributing information to the prescription, so that traceability is preserved. What we want to do in terms of outlooks in collaboration, we want to converge with IHE specifications. So we want to make sure that the Belgian specifications are aligned in whatever is convenient for Belgium with the IHE specifications, but there might be some gaps, there might be some differences, as normal every country, but those should not be breaking, meaning that if someone has an international medication overview, that should still work in Belgium with just some small adaptations, and vice versa. So we want to converge with international specifications, and the IHE specifications themselves, they would actually be compatible with other specifications, not only other countries, but other initiatives, other global initiatives that are out there. So that's what we want to do from Belgium, is to make sure that we get something that's internationally interoperable. And the next slide, just for a very brief illustration of what this comes down to in terms of data objects connected. On the left, we have, this is the initial analysis that we have a medication line, which in FHIR is a medication statement, and it's linked to prescriptions, and it's linked to the products, and it's linked to the dispenses. So we have this, and it has relationship with other care sets like patients, care plans, diary notes, and everything else that we might have, but that was the focus. And I just use this image to show that as part of our FHIR specifications in Belgium, by the way, we are using R4, but as part of those specifications, we also make sure that the readers of the specifications, and this is actually a screenshot from the specification, they can see that the medication line is linked to a dispense and is linked to a prescription, and that relationship can be in two ways. So we have those relationships also studied, and yeah, that's what we're having. We are producing the medication lines at this moment. We have other care sets being developed, like the prescription. We also have ones that already developed, like the dispense, and we want to contribute to the IHE specifications and align with those. That's it. Thank you. Stéphane.
Thank you, José. Okay, situation in Switzerland. For sure, medication is a key topic for the continuity of care. If we look at some statistics, some articles, problems linked to the medication during the transition from one entity to another are big problems. There were some studies evaluating to up to 10% the problem of related to medication in the emergency care wards. So it's really considered in Switzerland as a key topic, and also as a kind of killer app for the new electronic patient record that was introduced 2-3 years ago in Switzerland, and which is slow to take off. Regarding the project itself on the demedication, we had in Geneva a limited prototype, which started more than 10 years ago in a small EPR infrastructure. We had a regional infrastructure, and we are now rebuilding the whole system based on the national electronic patient record platform. We wish to have a first productive pilot for the third trimester with at least 2 university hospitals. We have problems getting pharmacies and GPs in the project. I will come that on the main challenges. The pilot will be on one part of Switzerland, which is related to the structure of the electronic patient record platforms. We are a federated country, meaning that we have the responsibility is regional, and we have several electronic patient record communities. We have 8 different communities. One which is the most active in Switzerland is the one from the French cantons, from which Geneva is part of, and this project, e-medication project, is being developed within this community. However, we have a close follow-up by the federal government. They are looking at what we do, how we will succeed. They sponsored the initial studies. So we are working in close collaboration with the federal government with the hope that our approach will be able to be generalized over the whole country and put in the federal law defining the electronic patient record, and that they will add soon the e-medication system. Key challenges, the standards adoption is clearly one. The electronic patient record is now fully IHE based, so we have some ground platform already IHE based. Medication reconciliation, it's another key challenge. We do aggregation of the different things to produce the medication overview, but we do not do automatically the medication reconciliation. That has to be executed by physicians, by professionals, to determine if I add a new medication in the plan, what are the effects on the others? Is there interactions? So that's something that has to be done by physicians and then, of course, implemented in the primary systems. The deep integration into the primary systems is a problem. To motivate the primary system developers to implement first the connection to the deep integration of the electronic patient record, then the integration of the medication. It's partly a problem of cost, certainly also a problem of competencies in interoperability, in working with standards. And we hope to progressively be able to onboard other regions of Switzerland. Most of them are still afraid of the complexity of managing a medication plan, managing medication overview, and they are still in the position wait and see. For the future steps, we started, initially 2012, there was not the IHE pharmacy profiles at that time, so we had a fully proprietary solution. With the new version, we started a few years ago, and we decided for using the IHE pharmacy profiles, which are CDA based. And the EPR platform is still mainly CDA based. Now, with the medication prototype, we moved to FHIR equivalent to the CDA documents. So there is a CDA document for a prescription, for a plan, for a dispense, for a medication list. We moved we made one step towards FHIR, making bundles with these documents and having the equivalent information in the FHIR bundles. But of course, the goal then is to move to the new IHE pharmacy FHIR-based profiles. And once they are published, we'll start smooth transitions towards these resources. Sharing ideas and experiences, it's a key point. We do it today, we do it within IHE Pharmacy, within other events. If we look at the previous presentations, there are several points that I didn't put on the slides, but for which we have exactly the same questions, the same problems. Like Rutt mentioned, the business rules, we have the same. So maybe we'll not have exactly the same business rules, but knowing how the others did and solved the problems and sharing the experiences is a key aspect of the project. And finally, in terms of future, one thing we are working on is how to lower the entrance step for primary systems developers. We are missing competencies, we are missing experience on that side, and we have to find ways to simplify the use of the standards, the use of interoperability profiles to them. Can go to the next slide. That's one of the foundation picture we have in the project, showing why we cannot create the medication overview only from prescriptions and dispenses. You have the two lower parts with the prescriptions, the dispenses. It's rather easy to get this information because the pharmacists are well structured. They have computing systems since many, many years. But if you look at the whole journey of a patient, you have many, many events that are described in the blue part that are not reflected in the prescription and in the dispense. So if you want to build a good, complete medication overview, you have to take into account all the different steps and include all actors. The physicians, the pharmacists, the nurses, the one who will dispense, and of course the patient also himself, because he may add medication, he may add notes, he may put different information in the plan. So he's also an actor. So it's making the whole system more complex, but it will be more complete and give more reliable information. And just for showing the documentation, the next slide, that's the different bundles we have. So as we started with the CDA and we moved to FHIR, we had an interim period where we decided to support both, saying, well, primary systems may use CDA, may use FHIR. So we have to have the equivalent in FHIR. Now we abandoned completely the CDA, but we are still document-based because the whole EPR platform is document-based. And it's also a bit simpler if you have a fully distributed system, different communities, different storage systems to be document-based instead of fully having a FHIR tree of resources. That's all for Switzerland, and I leave now the floor to Arianne for the Netherlands.
Yes, thank you very much. Right on time. This is the overview slide of the Netherlands, which I will explain using individual slides. So don't worry if you haven't read it all, and I'll present it again at the end as well. So why are we even working on medication at the moment in the Netherlands? This is because we have 75 avoidable hospital admissions due to medication errors per day, which of course we need and want to diminish. So one of the goals of the current program that we're working on is to have a good medication overview, actually a computer generated good medication overview generated by the computer as much as possible so that reconciliation by physicians is reduced to a minimum so that they can actually spend their time on treating the patient instead of getting the information correct. Today, I will mainly talk about the right-hand side of this medication overview given the time limit, but the left-hand side is also important. Just to let you know what is our current situation in the Netherlands. We do send digital prescriptions from prescribers to pharmacies, but that information is unfortunately not shared in the rest of the country. So only between the individual prescriber and the individual pharmacy. The pharmacies, as Stéphane was saying, are also very well structured in the Netherlands. And actually, we have dispense information flowing around the country of a coverage rate around, approaching 100%. So we do have a lot of information flowing around. But then, as both Rutt and Stéphane explained already, there's a problem with that logistic information because it's both too much and not enough. It's too much because it's logistically driven and it's hard to distill the medical relevance, and it's not enough because you miss information like dosage reductions and stop orders for which there's no logistic events. So we want to move from the current situation to a new situation that improves matters. And for that, we've come up with a model that actually separates out the therapeutically relevant information from the logistic information. So here you see the model with all the medication building blocks. The top line, the top horizontal line, the blue, are the therapy building blocks, whereas the bottom line represent the logistic building blocks, and they're separated out. The columns are actually the different processes in the medication process, so prescribing, dispensing, administering, using. So not surprisingly, for the medication overview, the therapy line is actually the most important. The logistics line, of course, is important in the medication process, but not so much for creating the proper overview. The challenge in the Netherlands is that we have a distributed care system. So there's different organizations in the Netherlands that actually create instances of these medication building blocks all the time. A hospital will create almost all of them, but a general physician will also do his part. Whereas, of course, the thrombosis service might be involved. There's definitely a pharmacy involved. There might be other private clinics doing stuff. And then, as Stéphane was saying as well, a patient himself may also tell stuff about their medication that you need to know. So you need to have a way to work together in this distributed environment. And so we've come up with a concept, medication treatment, which I think Rutt has already mentioned as well and explained really well. The way I explain medication treatment is basically the same. You want a proper row in a medication overview, and that row is about a certain medication treatment for that patient. So you need to bind together all these instances using the medication treatment. So actually all of these instances in this model have an identification or share an identification of this medication treatment. So you know which ones belongs together when you work together in a distributed environment. It's not enough because then again, you need the business rules that my predecessors were talking about. So for the medication overview, there's actually 3 building blocks that are very important: a medication agreement from the prescriber, the administration agreement from the pharmacist, and then the medication use that may be registered by a physician or by a patient. And then there's the business rules, making sure that you can create a medication overview containing current medication, future medication, and recently discontinued medication, which is important to know. And as my predecessors were telling as well, this medication overview may differ depending on the user you're presenting it to. I just want to also spend some words on how do we use this in the exchange, the actual information exchange. How do we map this onto HL7 and FHIR? At the moment, the dispenses are based on HL7 version 3 messaging. And for this new model, we've chosen to support both HL7 version 3 CDA clinical statement and HL7 FHIR. We're not as brave as Switzerland yet to just say, use FHIR. We need to keep our vendors on board at the moment. So we're doing both. Just want to briefly explain that actually HL7 version 3 CDA maps really nicely on the therapy logistics paradigm, because all of the therapy building blocks map onto substance administration, whereas the logistics building blocks map onto supply. As for FHIR, FHIR has taken more of a process approach. So each column in our model actually represents a resource in FHIR. Now this makes especially the prescribe and dispense mapping a bit artificial, if you like, because for a medication agreement, we use medication request, but we don't use every field. And then for the dispense request, we also use medication request, but then fill the logistics information. And you have to look at the category in the instance to find out which is which. So it's a bit more artificial, but it will work. Then a few words about the program. We're currently implementing and testing with vendors in different sectors. And after they build this, they will go live in 2 regions. And after some initial testing, we'll add more volume in those regions. After which, of course, we want to add regions and then want to progress to nationwide. It will take a couple of years before we're there, but it is in the current planning. So that's in, the 10 minutes I've been giving the medication overview strategy we have in the Netherlands at the moment. And I promised to get back to this overview slide, but I think I've told you about virtually everything, except maybe I didn't mention the translating mapping yet, because of course having the different formats and also the different versions still live in the Netherlands, we do help the market as well, specifying how to map one to the other. Having said that, I think I'm done and we can go to the questions and answers. Carlien, you want to take over now?
Sure, thank you very much. So please, for anyone who has any question, raise your hand, unmute yourself and speak up. I do have a question for you, Arianne. You say that the first vendors are already doing some tests. When will they go live with their test phase?
I think it's the current planning is about a year from now.
And what kind of, do you have different type of vendors there? First lines,
yes.
Hospitals?
Yes, we have the main hospital, the main Dutch hospital, EHR available. And then we have, I think, 2 primary or general physician suppliers. We have mental care, we have thrombosis. We have, oh, what am I forgetting? Oh, administration systems, actually, that like in the home care situation will need an administration list for their patients so that they can administer their patients. We have suppliers for that. Am I forgetting? Oh, pharmacies, of course.
And will you allow patient participation in this first phase?
No. Well, yes and no, of course. Patients are participants by definition.
But active
yes,
participation, I mean.
Not by digitally sharing information from their personal health record yet, but they can use portals that these suppliers, these vendors offer them, for example, via website. But yeah, it is envisioned for the future, but not in the first phase, no.
So that they can manually input through a patient portal. Like right. I've taken an additional painkiller today, for example.
Exactly, yes. Or I'm taking it every day, yeah.
I was optimistic. We do have a hand raise from Derek. So Derek, if you unmute yourself, you can speak up.
Thanks so much. And this was really interesting and very well done. So kudos to everybody. I have two questions. The first one was the one I had before this excellent discussion just now. The first one I had was, have we found where there seems to be significant overlap? Have we seen technically where there's a fertile place for us to develop an IHE profile that could be leveraged and rolled out by all of the examples that we saw? And I apologize if it was obvious to everybody else, but it's a little bit early in the morning here for me still, and I couldn't quite follow it from across the presentations. But the second question is this one about the patients. I'm sorry to stack them up like this. Where patients are allowed to say, this is what's true for me right now, it also opens up an attack surface for somebody that wants to, for example, get extra opioids provided to them by saying they've accidentally dropped some in the lake. That's been such a problem in other jurisdictions. We still struggle with that here in Canada. I know in the United States it's been a real situation. Is there a worry, or is there some plan for how that aspect of things could be addressed if we're going to let patients provide information directly into this? So sorry for that. I've asked two questions instead of just one, and I didn't mean to be greedy, but there it is. Thank you.
José, I think you want to answer to Derek.
Yeah, I'll take this one. Thank you, Derek. Very good questions. So on the first one, if I understand well, if there's an overlap, there is a substantial overlap. So when we're talking consistently in these countries around about the notion of medication treatment or treatment lines and those things. So the business rules themselves, they will be different, but the existence of a medication treatment plan as the backbone of these are the medications that we have the patient on, whether that means intended, real, stated, etc. Those things, the backbone of information is there. So yeah, these lines, those are things that we can that there's overlap in the sense of coincidence of or alignment of expectations there. All the business rules, what is these green lines and gray lines, as Rutt was indicating, this is, we assume that they started taking this medication, but that's an assumption that might be valid or completely invalid. So there's this overlap. And going back to your second question and taking this, so discussion on these matters, it has started a long time ago, 2001, no, 2000 and actually 2011. 2011. So sometimes we cannot accept that, so we cannot expect that whatever the patient states is correct. We can also not we can also have similar, much less challenges around some information that is obtained from another system because it's not a homologated system, etc. So I think the answer for that is the medication lists will contain the lines, and those lines are a result of whatever algorithms of reconciliation, deduplication, etc., and validation are expected. So, for example, I would expect a rule that if the patient says, yes, I have taken my antipsychotic drugs, that depending on the situation, that might be something that the physicians might say, yeah, let's put a yellow flag on this because it's not to be taken truly. If the patient says, I have not taken my opioids or I have taken all my opioids, that might be also some of those flags that will come from business rules. So yes, the notion of there is so much uncertainty around these rules and what is true or not, that we cannot standardize that. We cannot standardize the business processes around that and the business rules around that. What we can see is what is the common backbone of information that we can exchange, knowing that what is true in one country might not be true in the other. For example, this is the current situation, to my knowledge. In different countries, what is the current list of medications will vary because some countries will go a few months back, some countries will go a few years back, and that already makes the difference that what is true in one country might not be true in the other. So knowing that these rules will be different, what we have been doing is how can we handle this in a way that these rules can be independently applied on the same objects so that we know what is happening. And by the way, there's also a notion of the flavor, like if I receive something with a Belgian flavor, and then I know that the Belgian rules have applied to this, but this is no different from the other document, FIRE documents or CDA documents infrastructure. I hope that addresses the topics that you very validly raised, Derek.
Do you want to reply, Derek?
It does. It's a very helpful response, and thank you for it. It maybe means that the format or the data model that we're going to use to show a graphic like the one that's on the screen could be quite consistently defined, but how the content got into making the shapes might be very different, could be significantly different. And it is interesting that it would mean that a graphic you see from another country might not map well to how it would be understood across a border. And that's an interesting notion. It might mean the business rules should have to travel with the graphic if this was content that was being shared in a cross-border situation. But you know, maybe it's ever thus. I see Stéphane wants to.
Yeah, if I may add to José's answer, what is not shown on the graphic is the real intake. And in Switzerland, we'll not document the real intake because except for intravenous, for injections and things like that, you will never be sure that the patient took or did not take the medication. So your situation where the patient will use this graphic to get more boxes, it will have no influence on that, because what the pharmacist will see is what was prescribed and what was given. The fact that the patient lost or intentionally resold the box is not documented, and it's not the problem of the pharmacist in a sense. And that's also your concern is also a reason. In the Swiss electronic patient record, the patient may hide documents, may make them secret, and no healthcare professional can see them. We explicitly forbidden that action in the medication plan, because otherwise it will exactly lead to your concern. The patient could hide a dispense and then ask for a redispense. So that will not be possible for the patient to hide any information. It will be see everything or see nothing. Either the professional can see the plan and all information in the plan, or he cannot see anything, but no hidden information by the patient.
Thank you.
Thank you. It's a very interesting topic, right? We face a lot of challenges. There are some privacy things for the patient, but there's indeed a lot of concerns there. So as we try to stick to the schedule, and we all know that you're very busy, and probably another meeting is already awaiting for you. Thank you very much for joining us today, and please stay tuned to our website for our next webinar will be on the 9th of February. Thank you so much. Have a nice day, and thanks again, Stéphane, José, Arianne, and Rutt. Bye-bye.
Bye-bye. Thank you.
Thank you. Bye-bye.
Thank you.
Good afternoon.
Bye-bye.
Thank you. Bye-bye.